April 15th, 1945. Walter Reed Army Medical Center, Washington, D.C. The surgical suite's overhead lights cast harsh shadows across the operating table, where Captain William Morrison lay dying. 3 hours earlier, shrapnel from a German 88mm shell had torn through his abdomen during the final push across the Elbe River. Now, 4,000 miles from that battlefield, the young officer's blood pressure was dropping faster than the surgical team could compensate. Major Sarah Chen, one of the few female surgeons in the Army Medical Corps, watched the crimson fluid pooling beneath the table. Morrison had already received 2 units of whole blood, but his body was rejecting the transfusion. His kidneys were shutting down, his breathing became labored, and the EKG monitor showed the irregular rhythm that preceded cardiac arrest. What Major Chen didn't realize as she fought to save Morrison's life was that she was witnessing the final moments of medicine's most primitive era. Within hours, a revolutionary discovery made 2,000 miles away in a University of Chicago laboratory would transform not just battlefield medicine, but the entire foundation of emergency medical care. The mathematics of survival were being rewritten, not in operating rooms, but in research facilities where scientists had unlocked the secret of separating life itself into its component parts. The transformation had begun 3 months earlier when Dr. Charles Drew, the brilliant African-American physician and researcher, received an urgent telegram from the Office of Scientific Research and Development. The message was brief, but carried implications that would echo across decades. American casualties in Europe were dying not from their wounds, but from the inability to transport whole blood across vast distances without spoilage. Traditional blood banking required refrigeration at precisely 39 degrees Fahrenheit and had a maximum shelf life of 21 days under perfect conditions. By the time whole blood reached field hospitals, it was often contaminated, clotted, or chemically deteriorated beyond safe use. Drew had spent years studying blood preservation at Columbia Presbyterian Medical Center in New York, where he had developed techniques for large-scale blood collection and storage. But the challenge of battlefield medicine demanded something unprecedented. Military commanders needed a blood product that could survive weeks in transport, function in extreme temperatures, and remain stable under conditions that would destroy conventional whole blood within hours. Drew's solution would seem obvious in retrospect, but in 1944 it represented a conceptual breakthrough that most medical authorities considered impossible. The key insight came during a late December experiment in Drew's laboratory. Working with plasma, the liquid component of blood after red cells had been removed, Drew discovered that this golden fluid retained most of blood's life-saving properties while eliminating its most problematic characteristics. Plasma didn't require typing and cross-matching like whole blood. It could be frozen, dried, reconstituted, and stored for months without refrigeration. Most importantly, it could expand blood volume and maintain blood pressure, the critical factors in treating shock and massive hemorrhage. But plasma's advantages went beyond simple preservation. When Drew's team analyzed the composition of dried plasma, they found it contained proteins, antibodies, and clotting factors that made it superior to whole blood for many emergency applications. Albumin provided oncotic pressure that kept fluid in blood vessels. Gamma globulin offered antibodies against infection. Fibrinogen enabled clotting. Together, these components created a medical product that could address multiple aspects of trauma simultaneously. The first large-scale test came in February 1945, when the Army Medical Research Command shipped 500 units of dried plasma to field hospitals in Belgium. The results were immediate and dramatic. Soldiers who would have died from blood loss survived. Shock patients who couldn't be stabilized with whole blood responded rapidly to plasma infusion. Most remarkably, medics could administer plasma in field conditions without the complex preparation required for blood transfusions. Captain James Martinez, commanding the 47th Field Hospital near Remagen, documented the transformation in his medical reports. Previously, soldiers with severe blood loss had required immediate evacuation to rear area hospitals equipped for transfusion medicine. With plasma available, frontline medics could stabilize casualties who might otherwise have died during transport. Martinez recorded that survival rates for hemorrhagic shock cases improved by 340% during the first month of plasma deployment. The production challenges seemed insurmountable initially. Each unit of plasma required processing 450 milliliters of donated blood through centrifugation, separation, filtration, and freeze-drying. The equipment needed for large-scale production didn't exist. Manufacturing facilities capable of producing thousands of units daily would need to be built from nothing. Yet American pharmaceutical companies, led by Abbott Laboratories and Cutter Laboratories, accomplished this industrial transformation in less than 4 months. The Abbott facility in North Chicago represented American industrial mobilization applied to medical production. Built in an abandoned aircraft parts factory, the plant featured 47 centrifuges operating continuously, processing rooms maintained under sterile conditions, and freeze-drying chambers that could handle 2,000 units simultaneously. By March 1945, this single facility was producing 15,000 units of dried plasma weekly, more than the entire American medical system had used in the previous decade. Worker training followed the same rapid deployment principles that had revolutionized wartime manufacturing across industries. Traditional medical technicians required years of education to work with blood products. Abbott's training program produced competent plasma processors in 6 weeks. Former factory workers, housewives, and recent high school graduates learned to operate centrifuges, monitor sterile procedures, and package dried plasma with precision that equaled university-trained laboratory specialists. The quality control standards exceeded anything previously attempted in medical manufacturing. Each batch underwent testing that would have been considered excessive for peacetime pharmaceuticals. Sterility checks using 3 different bacterial culture methods, protein concentration analysis through spectrophotometry, stability testing under extreme temperature conditions, potency verification using controlled animal studies. The result was a medical product more reliable than most whole blood available in civilian hospitals. Spring 1945 brought the ultimate validation of plasma's revolutionary potential. As Allied forces advanced into Germany, plasma supplies enabled medical capabilities that transformed battlefield surgery. Field hospitals could now attempt complex operations previously impossible outside major medical centers. Surgeons could maintain blood pressure during lengthy procedures, treat multiple casualties simultaneously, and save soldiers who would have been written off as untreatable just months earlier. The psychological impact on medical personnel proved as significant as the clinical benefits. Major Helen Rodriguez, chief nurse at the 12th Evacuation Hospital, described the transformation in her letters home. Previously, medical staff had worked under the constant knowledge that many casualties couldn't be saved due to blood loss. With plasma available, treatable injuries remained treatable regardless of bleeding severity. The sense of helplessness that had haunted battlefield medicine since ancient times was finally lifting. But the most profound discovery was yet to come. As medical officers analyzed plasma usage data from hundreds of field hospitals, patterns emerged that would fundamentally alter emergency medicine's future. Plasma wasn't just saving lives on battlefields, it was creating treatment protocols that could revolutionize civilian medical care. The rapid response techniques developed for military trauma could transform how civilian hospitals approached emergency cases. Dr. John Thompson, analyzing casualty data for the Army Medical Research Command, identified the critical insight that would reshape medical practice. Speed of intervention mattered more than perfect diagnosis. Patients who received plasma within the first hour of injury had survival rates 60% higher than those treated after 2 hours, regardless of the specific nature of their injuries. This time-critical factor had never been quantified before, but plasma's standardized administration made it measurable for the first time. The implications extended far beyond military medicine. If rapid intervention was the key to survival, then civilian hospitals needed systems designed for speed rather than deliberate diagnosis. Emergency departments would need to be reorganized around immediate stabilization rather than comprehensive evaluation. Medical personnel would need training in rapid response procedures rather than traditional methodical approaches. As reports from European battlefields accumulated through spring 1945, a new understanding of emergency medicine began emerging from the data. Trauma care was not about perfect surgical technique or sophisticated diagnostic procedures. It was about maintaining circulation, preventing shock, and buying time for the body's own healing mechanisms. Plasma had provided the tool that made this approach possible, but the organizational changes required would prove even more revolutionary than the medical breakthrough itself. By June 1945, civilian hospitals across America began receiving their first shipments of dried plasma. But the medical establishment's response revealed how unprepared peacetime medicine was for this revolutionary technology. At Massachusetts General Hospital, Dr. Richard Pemberton, chief of surgery, examined the small vials of golden powder with deep skepticism. His surgical service had functioned successfully for decades, using careful patient selection, meticulous preoperative preparation, and acceptance that certain cases were simply too risky to attempt. The arrival of plasma challenged everything Pemberton's generation had learned about surgical limits. Cases previously deemed inoperable due to blood loss risks could now be attempted. Emergency procedures that required hours of preparation for blood typing and cross-matching could begin immediately with plasma resuscitation. Most disturbing to traditional surgical hierarchy, emergency room physicians could now stabilize patients that previously required immediate surgical intervention. The first civilian plasma save occurred on June 23, 1945, at Cook County Hospital in Chicago. Margaret Sullivan, a 34-year-old factory worker, arrived in the emergency department after an industrial accident had severed her femoral artery. Under conventional protocols, Sullivan would have been rushed directly to surgery while staff frantically prepared whole blood for transfusion. Instead, Dr. Robert Kim, one of the few emergency physicians who had trained with military plasma protocols, immediately began plasma infusion in the emergency bay. Within 20 minutes, Sullivan's blood pressure had stabilized at levels that would have required immediate surgical intervention just months earlier. The plasma bought precious time for proper surgical preparation while maintaining circulation that kept her conscious and responsive. Dr. Kim's treatment notes, preserved in Cook County's medical archives, captured the moment when civilian emergency medicine glimpsed its future. Patient remained stable throughout 2-hour preparation period. Plasma maintained adequate perfusion despite massive blood loss. Surgical repair completed successfully with patient in optimal condition. The transformation spread unevenly across American hospitals through the remainder of 1945. Urban medical centers with connections to military research programs adopted plasma protocols rapidly. Rural hospitals, dependent on traditional medical supply chains, continued operating under peacetime constraints that now seemed primitive by comparison. The disparity created a two-tiered medical system where survival increasingly depended on which hospital a patient reached first. Dr. Elizabeth Warren, appointed by the American Medical Association to study plasma implementation, visited 47 hospitals across 12 states during the summer of 1945. Her confidential report revealed the magnitude of organizational change required to fully utilize this new capability. Hospitals successful in plasma deployment had restructured their emergency departments around speed rather than deliberation. They had trained nurses in rapid intravenous access techniques previously known only to anesthesiologists. They had developed protocols that prioritized circulation maintenance over diagnostic precision in the critical first hour. Hospitals that treated plasma as simply another medication to be prescribed by physicians after careful evaluation saw minimal benefit from its availability. The technology alone was insufficient. The entire approach to emergency medicine required fundamental reorganization around the principle that time was the enemy and rapid intervention the primary weapon against death. The economic implications proved equally revolutionary. Plasma's stability and ease of administration reduced the need for specialized blood bank facilities that had required significant capital investment. Small hospitals could now stock life-saving capability that previously demanded laboratory infrastructure beyond their resources. Rural emergency departments could attempt treatments that previously required immediate transfer to urban medical centers. Manufacturing costs fell dramatically as production scaled up through late 1945 and early 1946. Abbott Laboratories reported that plasma production costs had dropped to $3.47 per unit, compared to $12.15 for processed whole blood when all collection, testing, and storage costs were included. The economic advantage enabled hospital administrators to stock plasma in quantities that would have been financially impossible with traditional blood products. By December 1945, American Red Cross chapters had established plasma collection centers in 127 cities, creating a civilian blood supply network modeled on wartime military systems. The collection process, streamlined through industrial efficiency principles, could process a donor from arrival to departure in 35 minutes, compared to the 2-hour procedure required for whole blood donation under peacetime standards. Training programs developed during wartime production proved equally valuable in civilian implementation. The 6-week plasma technician certification program, created by Abbott Laboratories, was adopted by hospital associations nationwide. By early 1946, over 3,000 civilian medical workers had received training in plasma preparation and administration, creating a workforce capable of supporting the new emergency medicine paradigm. The first comprehensive study of civilian plasma effectiveness came from Los Angeles County Hospital, which had implemented military protocols in September 1945. Dr. Michael Torres, Chief of Emergency Medicine, analyzed 1,847 trauma cases treated between September and December. His findings, published in the Journal of the American Medical Association in March 1946, provided statistical proof of plasma's transformative impact. Mortality from hemorrhagic shock dropped by 67% compared to pre-plasma baseline data. Time from arrival to surgical intervention decreased by an average of 73 minutes. Most significantly, the number of cases deemed too unstable for surgery fell by 81%, indicating that plasma was enabling treatments previously considered impossible. But Torres identified an unexpected consequence that would prove crucial to emergency medicine's evolution. With plasma available for rapid stabilization, emergency departments were seeing increased survival rates across all trauma categories, not just those involving blood loss. The aggressive early intervention protocols developed for plasma administration were benefiting patients with head injuries, cardiac events, and respiratory emergencies who received faster, more intensive initial treatment. The data suggested that the real revolution was not plasma itself, but the systematic approach to emergency care that plasma deployment had necessitated. Speed, standardization, and immediate intervention were proving superior to the traditional model of careful evaluation and deliberate treatment planning. Emergency medicine was discovering its own identity as a specialty distinct from surgery, internal medicine, and other established disciplines. As 1946 began, hospitals across America were implementing organizational changes that would have seemed radical just 18 months earlier. Emergency departments were being redesigned with multiple treatment bays for simultaneous patient care. Nursing staff were receiving training in procedures previously restricted to physicians. Supply systems were being reorganized to ensure immediate availability of emergency medications and equipment. The transformation was accelerating beyond what anyone had anticipated. Plasma had provided the catalyst, but the changes it enabled were reshaping the entire structure of acute medical care. Emergency departments were evolving from simple triage centers into sophisticated treatment facilities capable of complex interventions. The modern emergency room was being born from the convergence of wartime medical innovation and peacetime implementation of systematic rapid response protocols. The revolution gained unstoppable momentum through the spring of 1946, as a new generation of physicians emerged from military service carrying radical ideas about emergency medical practice. Dr. Frank Castellano, recently discharged from the Pacific Theater, arrived at Detroit Receiving Hospital with protocols that seemed to contradict everything civilian medicine had established as proper procedure. His first shift demonstrated how profoundly military plasma experience had changed medical thinking. A construction worker arrived unconscious after falling from scaffolding, his vital signs fluctuating wildly. Traditional hospital protocol required careful neurological evaluation before any intervention. Castellano immediately initiated plasma infusion while simultaneously ordering rapid diagnostic procedures. Within 40 minutes, the patient was stable enough for surgery that saved his life. The attending physician, Dr. Harold Morrison, watched in amazement as techniques developed for battlefield trauma proved equally effective in civilian emergencies. Morrison's subsequent report to the hospital administration captured the generational divide transforming American medicine. Military physicians had learned to treat the patient first and determine the diagnosis second. They prioritized circulation and oxygenation over careful examination and deliberate consultation. Most importantly, they had abandoned the peacetime luxury of extended evaluation in favor of immediate life-saving intervention. The philosophical transformation proved as significant as the technical innovations. Traditional medical education emphasized diagnostic precision as the foundation of proper treatment. Military medicine had discovered that maintaining life took precedence over understanding disease. Plasma had made this approach possible by providing a universal stabilizing agent that worked regardless of specific pathology. By summer 1946, medical schools were grappling with curriculum changes that reflected this new reality. Johns Hopkins Medical School, long considered the pinnacle of American medical education, found itself revising fundamental courses to incorporate rapid response protocols. Dr. William Halstead's principles of meticulous surgical technique, which had dominated medical education for 50 years, were being supplemented by emergency procedures that prioritized speed over perfection. The resistance from established medical authorities proved intense and occasionally bitter. Dr. Charles Hamilton, president of the American College of Surgeons, published editorials warning against the militarization of civilian medicine that abandoned careful diagnosis in favor of cookbook protocols designed for battlefield expediency. His criticism reflected genuine concern that emergency medicine was sacrificing the intellectual rigor that separated medical practice from mere technical procedures. Yet the statistical evidence continued mounting in favor of rapid intervention approaches. St. Mary's Hospital in San Francisco implemented comprehensive plasma protocols in August 1946, treating emergency cases with military-style triage and immediate stabilization. Their 6-month analysis revealed improvements that silenced most critics. Overall emergency department mortality fell by 34%. Time to definitive treatment decreased by an average of 89 minutes. Patient satisfaction increased dramatically as families watched their loved ones receive immediate attention rather than waiting through lengthy evaluation procedures. The economic impact extended beyond individual hospitals to reshape healthcare financing nationwide. Insurance companies discovered that rapid emergency treatment reduced overall medical costs by preventing complications that developed during extended evaluation periods. Metropolitan Life Insurance Company's actuarial analysis showed that hospitals using plasma protocols had 28% lower average treatment costs per emergency case, primarily due to reduced length of stay and fewer secondary complications. By December 1946, the transformation was complete. Captain Morrison, whose near-death experience had marked the end of medicine's primitive era, would have found himself in a medical world utterly transformed from the one that had nearly failed him. Emergency departments across America now operated on principles born from wartime necessity, where plasma had taught physicians that speed conquered death more surely than deliberation. The golden vials that Drew's laboratory had perfected hadn't just saved individual lives. They had rewritten the fundamental equations of emergency medicine, proving that systematic rapid response could accomplish what centuries of careful diagnosis never could. Every modern emergency room with its trauma bays and rapid response teams stands as testament to the revolutionary discovery that sometimes the most profound medical advances come not from understanding disease better, but from learning to fight death faster.